you're not alone. Surviving is part of it, but you're not alone in wanting to thrive.
Yeah.
You're allowed to talk about how your journey, whatever that looked like, impacted you. And again, it's not being ungrateful. It's just being honest. Seek out those that have shared experiences and educate your clinicians, whatever kind of medical trauma you have.
Welcome to the Medical Trauma Support Podcast, where we come together to bring more humanity into healthcare. I'm your host, Sarah Stasica. Hello, everyone, and welcome back to the Medical Trauma Support Podcast. Today, I have Kali Dayton with me. Hi, Kali.
Hi. Thanks for having me on.
Yeah, I'm glad you're here. And Kali is a nurse practitioner and an ICU consultant. I know there's a lot more to you, so I thought I would open it up for you to just share a little bit more about yourself.
Yeah, I have been a nurse for a long time. I graduated in 2009 with my associates in nursing, and I gallivanted through the world and did a lot of other things. And so when I came back to the States after 3 years of having my license, I found myself interviewing into a very high acuity ICU in Salt Lake City, Utah. And the nurse manager asked me during that interview almost immediately, would you be willing to walk intubated patients who were on ventilators? And I had no idea what that really meant, right? Again, I was so new, but I was like, just wanted the job. So I said, yes, absolutely, of course. And when I worked in that ICU, it was normal there to have patients with breathing tubes connected to ventilators who were extremely sick to be awake right after the procedure of putting the breathing tube in, to have them writing on clipboards, whiteboards, even typing on their computers, communicating with us, and then oftentimes walking through the halls, walking in their room, sitting in a chair. And so we can get into it more later, but that's really the roots of my experience as a nurse. Most of my experience is in critical care in the ICU, and I came to find that was a very unique experience that has transformed my career and now is helping change the care and the lives of innumerable patients.
That's amazing. I would love to keep going in what you're talking about, and how you started out as a new nurse and not really knowing what that meant, but how that brought you to where you are at this point.
Well, I never questioned what we were doing there, right? I never worked in another ICU. Granted, okay, we can rewind a little bit more. When I was doing some rotations as a nursing student, I did spend a few shifts in the ICU, and I was so excited because I wanted the hardest, coolest, craziest job, right? And so I thought I just really felt called to the ICU. So when I got the chance to go into the ICU as a student, I came in with guns a-blazing, so excited. So, I mean, I was 19 years old as a nursing student, right? 18 to 19 years old. So, and I was a chatter, and I came in, it was there for night shift. And this very seasoned nurse as a night shift nurse was like, whoa, hold on. I work in the ICU and on nights so that I don't have to talk to patients. So if you think this is going to be social hour, you're strongly mistaken. And I was like, oh, it broke my little heart. And I just shut up. And I really didn't know if I would end up in the ICU because that experience was so cold. Right. I loved people, but I didn't have a lot of interactions. But I still spiritually just felt very called to the ICU over this next few years while I was, again, gallivanting through Central America and the Middle East and things like that. So when I came back and I got the opportunity to interview in that ICU, I was like, I still want to try. I still want to see. Yeah. And I quickly forgot that first interaction or introduction to the ICU because, again, it was the exact opposite in this new ICU. And again, I didn't question it because I really didn't know much else. And everyone else treated it like it was normal to have patients awake and interacting and walking and doing all these things. And in my heart, it made sense. My patients are human. Of course, they're going to be awake during the day, telling us what they need so I can meet their needs. I can know what they want during some of their most vulnerable and critical moments of their lives and potentially final moments of their lives. Yeah. I had some of the most sacred experiences with patients telling me that they want to keep fighting to survive or that they're done. Right. And we could choose everything for their going home party, I would call it, their farewell party, the music, the guests, sip from 7-Eleven Slurpee, right? Yeah. So I loved that environment experience, but I was still really young. And after a few years, I wanted to have more experiences, and I became a travel nurse to go explore the world. And no one really prepared me for what it would be like elsewhere.
Mm.
And I went to my next assignment into the first new ICU, and the lights were down. It was dark. Every patient was in bed. They were all had their eyes closed. And I thought, okay, well, it's 7 o'clock, but maybe they just have a different schedule here. They don't get everyone going yet. But that didn't really change throughout that shift. And my assignment included a patient that was intubated or on a ventilator with a breathing tube, and they were not responding to me. They had sedation running, and I couldn't figure out why we needed that sedative drip. So I asked the nurse that was there, kind of overseeing me, because I was new there. You have to have someone orient you to that new environment.
Yeah.
I asked her the very innocent question of, why is this patient sedated? And can I take it off, turn sedation off, and get them up to the chair? And this nurse looked at me in absolute shock and horror and said, no. And I said, okay, why? And she said, because she's intubated, which is how we say they have a breathing tube, right?
Mm-hmm.
Tube down their throat, they're connected to the ventilator that's being intubated. And that was really confusing to me because, again, I had treated hundreds, if not more, patients that were intubated but awake and walking. And I said, okay, no, she's intubated, but why is she sedated? And she said, as if it was just so obvious that I should know the answer, she said, because she's intubated. And I said, okay, but why is she sedated? And we went in circles. And so, Sarah, that was the first time I'd ever considered the idea or the concept that someone would automatically be in a medically induced coma just because they have a breathing tube. But I came to really quickly realize that that was what everyone else believed and thought, and that's how they functioned. And so I realized that I was not in Kansas anymore. And that when I tried to explain, okay, well, where I come from, we would just walk these patients. They thought I was crazy. They thought those weren't sick patients that I had treated, that this was a different, more of like a rehabilitation center that I had worked at, not an ICU with sick people, which is not the truth, but I just didn't know how to dispute it. I also didn't know the reality and the risks and the harm of medically induced comas. No one had sat me down and said, hey, this is a really special place that you work in. We do things very differently, and here's why we do this. Here's what everyone else does, and here's why we don't put them in medically induced comas. I had no idea. So yeah.
Can I ask you first, like for people listening, like, is it 99% of ICUs that are operating like this one that you got to? Like, what does it look like right now?
The ICUs, like the one I came from, are very, very rare and far between, especially in most countries. Now you have countries like Denmark, where that's the norm.
Okay.
They really don't use sedation for most patients, right? About like 80% of their patients are off of all sedation. And because there are times in which sedation is unavoidable. If someone's having seizures, if they have swelling or bleeding in the brain, and there's a lot of high pressure, there are times when it is medically indicated. So the rest of the time, those patients are completely awake. And they've been doing that for decades now. Otherwise, in other parts of the world, even in the USA, most patients are what I call on a conveyor belt, where you get the breathing tube placed, you put on the ventilator, and you will automatically be put onto this course of sedation. You will not move a muscle. We can talk about what this really means for patients, but that is the norm. There is a spectrum of approaches. Some teams will give some of the most dangerous sedatives. Other teams will avoid those sedatives, but still sedate them. Other teams will try to give lighter doses. So there's just a whole spectrum. But as far as being fully awake, involved in their care, communicative, informed, calling the shots, mobilizing, that is still the rare exception.
Yeah. And so it also sounds like there's not like a consistent process across the board for ICUs in the US.
No, there is. I mean, there are official declarations. We have certain guidelines, but they keep them pretty generalized because this requires critical thinking for each patient. So I listed some times in which we would give sedation. Yeah, there's a whole history as far as why we're here and why we're still struggling with this. But the official guidelines do guide us to keep patients as awake, communicative, autonomous, and mobile as possible. But whether or not teams comply with that or actually strive to do that, or even know how to do that or what that looks like. That really
Right.
depends on the unit.
Yeah, and the culture. There's a culture that, like you shared, it's when you're kind of going against a culture and the beliefs about how something's done, it's really challenging.
Well, and this is a culture that's been established for decades. It really
Yeah.
started back in the 90s. Before the 90s, medically induced comas weren't a thing. But
Mm,
in the 90s, we started to experiment with keeping patients that were much sicker alive for
mhm,
longer. We were having advancements in technology, ventilator technology, but we were experimenting with ARDS, or acute respiratory distress syndrome.
mhm,
This is a condition that patients can get for many different reasons, but this was very common during COVID, where
mm,
you'd have an injury to the lungs and lungs would become very inflamed and fill up with fluid and be very stiff, right? It's a
mhm,
very, very life-threatening condition.
mm,
But the theory back in the 90s was we should give tons of volume and tons of pressure into these lungs to force the lungs to inflate since they're so stiff.
mm,
So
mhm,
we were actually popping a lot of holes into the lungs with these
mm,
ventilators. It
mm,
was extremely uncomfortable for patients, and they were trying to do their own breathing against the ventilator. And so the question was, how do we make the patients stop breathing? How do we make them comply with what the ventilator is doing? So we
yeah,
started bringing up medications from the OR, the things that we use for general anesthesia,
right.
benzodiazepines, barbiturates, opioids, paralytics. And we knew it caused amnesia during surgery for a few hours.
Mhm,
And so we thought, why not do that during all of the critical illness that patients have? And so when we gave those medications to patients, they didn't take their own breaths, they didn't fight the ventilator. So it looked like we fixed the problem, but they
mhm,
also weren't moving. Their eyes were closed, and we thought that they were sleeping. We, as in the medical community, right?
yes,
So it really spoke to the tender hearts of clinicians to, quote, protect patients from trauma
yeah,
of the breathing tube, the environment of the ICU, the critical illness, the pain, all the bad things that happen to patients. If we can just make them sleep through it all, that's even better. What we didn't realize is that those sedatives actually disrupt the brain activity so much that the brain cannot go into REM cycle 3 and 4.
mm,
So it's actually a sedation induced sleep deprivation.
wow,
And the brain is already under attack from lots of different things during critical illness, low blood flow, low oxygen levels, pain, infection, inflammation, right? It's already under attack. And the sleep is how we cleanse our brains out from all of the harm, injury, things that we don't need, right? If we don't get sleep, even without being critically ill, we can develop hallucinations,
yeah,
delirium, right?
yeah,
That happens to people that are being tortured by sleep deprivation.
yeah,
So here we take these really fragile brains that are critically ill, and then we add in sedation-induced sleep deprivation, and we essentially destine them to have severe delirium, which is actually acute brain failure.
mm,
And that delirium doubles the risk of dying in the hospital.
wow,
And regardless of a patient's age, if they develop delirium, they're at 120 times greater risk of long-term cognitive impairments that are similar to mild Alzheimer's and moderate traumatic brain injury.
mhm,
But we didn't know this in the 90s, right?
right,
We thought that they were sleeping, and what survivors now have told me on my podcast, Walking Home from the ICU,
mhm,
is that they could still hear and feel things in their environment and around them. But in their delirium, that sensory input, for some reason, gets twisted into something much more graphic and morbid.
yes,
So they have horrific alternative realities. We can
mhm,
call them hallucinations, nightmares, but according to survivors, that doesn't really capture it. That what they experienced was more real than what you and I are experiencing right now.
yes,
And they might use those words to try to help us relate to them, but it's something that I don't think we really can relate unless we've experienced it.
yeah,
And that's very, very traumatic. Survivors have told me things like deeply believing during that time that their deceased father was cannibalizing them.
mm,
They were being sexually assaulted. They were
yeah,
kidnapped, or their kids were kidnapped.
mm,
They were trying to save babies from burning. And what is actually days to us can feel like years to them. They spend lifetimes going on these insane journeys, and then they get yanked back into this reality, which is where now by the time we take off that sedation, a lot of times they are so incredibly weak from critical illness consuming their muscles, not using their muscles, and sedation itself is very toxic to the muscles. So now, oftentimes they wake up and they still have a breathing tube down their throats, or maybe they've got a tracheostomy, and now they still are having these hallucinations. They think that we're their kidnappers, and they're in so much pain. It just expounds, and it can go on for weeks and months. People can leave and go to nursing homes still in delirium. They can go home and still be in delirium. The ICU clinicians are somewhat aware of delirium. Like, they know that patients get confused, but culturally it's interpreted as like transient confusion. So yeah, they'll kind of snap out of it when they leave the ICU, and they'll just remember it all as, a weird dream, a weird trip. They don't realize that they will likely have lifelong trauma and a brain injury that could change their ability to go back to work, to live independently, to drive, changes their relationships, it changes their identity, it changes so much about their lives, but we're so largely unaware of it that we don't tell people what's coming. We don't tell the families. We don't give any kind of heads up. And we especially are not aggressively proactive about preventing this. It's just the norm. So the perception is, something that nurses say all the time is, if I was intubated, I would want to be sedated. You better knock me out, give me all the drugs. I don't want to open an eye until it's time to take that tube out. Well, by that time, a lot of times they're too weak to breathe. So then it's really hard to take the tube out. So we've prolonged their time in that situation for far longer. And again, set them up for lifelong disabilities if they do survive that.
Right. And like, oh my gosh, when you were describing the experiences that, ICU survivors have shared with you, it's just like some of the most traumatic things that a human could experience.
And then on top of that, they're in this alternative reality. And even if they're not, right? Even if sometimes they don't have any experiences while sedated, but they've lost time. They're like, what happened to me the last 3 weeks? I had all these invasive things done. I don't recognize my body. My body doesn't move the way it did, or I'm so different now. But they've lost time. They lost control. Or they wake up and now they're too weak to hold a cell phone and text, to hold a pen and write. They've got a tube down their throats. They can't communicate. They've got questions. They're worried about their dog getting fed in the apartment, or their kid being picked up from daycare, or whatever, and they can't communicate. That alone is very traumatic, to be strapped down to a bed, tube down your throat. You can't talk. Nobody knows what you want, and they just tell you to calm down and shut up. Or they give you more sedation. So when you get upset and panicked, we respond to it with more sedation. Everything goes black again, and oftentimes they're shoved back into that alternative reality. And so that's part of their trauma.
I have so many questions, but I want to try to let people be able to follow where my mind is going right now. How to minimize or prevent this happening to them or a loved one in the ICU. And then I want you to share with people the work that you're doing to change this. And then I want to talk just a little bit about what recovery looks like when somebody's been through that.
So now, as a consultant, I train ICU teams to transform their knowledge, beliefs, perceptions, culture, skill set, and practices to become what I call an awake and walking ICU, which is like the ICU I came from. They started this process in the 90s, and I'm just trying to disseminate that throughout these ICUs to create ICUs in which we only give people sedation if there's an indication for sedation. And that includes providing informed consent, telling patients and families the risks of those things, warning them. Delirium can happen even without sedation. So it's an environment in which we are very, very aware of delirium. We know how to prevent it. We know how to treat it when it happens, because how long someone has it greatly determines how damaging it is. And patients are doing their highest level of mobility as soon as possible. And then families are part of the ICU team.
Wonderful.
Unfortunately, we still have a lot of visitation restrictions. my home ICU in part was able to do what it did because we didn't have visitation restrictions. Families were able to stay overnight. They were part of the team, and that's an essential part of being able to keep patients awake and calm and
Yeah.
oriented and knowing what's going on. You got to have their safest, most familiar people in that kind of environment. So
Yes.
I do a lot of education, consulting, and training with teams to make this whole transformation happen. It's really hard for these leaders to try to do something they've never actually done before or experienced, but yet they're supposed to lead it. So I provide that support. I go on site. I bring in other experts, other disciplines. So respiratory therapist, a physical therapist, other nurses. We try to meet the needs of each team and each
Mhm.
specialty to go in and figure out where are they currently at, what are their barriers, and how do we get them to that point where they hardly ever use sedation. It's a big overhaul, but we're having really exciting success.
That's amazing. So what do they go and visit this ICU in Utah like that you worked in?
Yes, I've sent a lot of people to that ICU because sometimes it's one of those things you just have to see it to believe it. So I've sent
Yeah.
people from around the world to go visit that hospital. What's exciting now is I'm able to send people to some of these other hospitals that I've trained.
Mhm.
So it's amazing to have them be in that position to now help lead it, to be examples of it.
Yeah.
Um, it is spreading, so more popping up.
One thing I'm really curious about is so some of the hospitals that you've already done the consulting with and helped them, start their walking and awake ICU. What is some of the feedback you get from them once they're at the point? Like, my guess is like change is hard. So my guess is there's a real messy middle,
Yes.
emotional, hard shift. But like, what is it like once it's up and running and they're starting to see the change?
Yes, there's a lot of hesitation, fear,
Yeah.
resentment. Like there's a lot to work through.
Yeah.
I'd say about 6 months after we do an on-site visit and do like all this practice and training with them, and if their leadership has been really good to support them to the point of just doing it, and they have a few months to really get in that groove and have repeated success and feel confident, and they can just see it with their own patients, they will say things that kind of make me laugh, like, well, why don't you tell us it'd be this fun? Why don't you tell us it'd be this easy? Or there's no way I'd want to go back. Or I'd rather have an awake patient right after intubation than a delirious patient not on the ventilator. Like this is so much better, easier. I feel like I'm actually making a difference. They get to have human connection. They get to watch patients just walk out the doors when that was so rare. If they did survive, they were very physically, cognitively, and psychologically impaired. And that's so normal that you don't really see it. You don't
Yeah.
really recognize it for what it is, or even they just didn't perceive it as something that was preventable. So now when they have so much success, they're like, yeah, we did that. Like, look at
Right.
the contrast. Um, there's just a lot of things that are really hard on the team that they just accepted as normal. So 6 months later, they look back and they're like, wow, this is entirely different and this is worth it.
Wow. Yeah. And I'm guessing you probably have some good numbers that you share with hospitals that are curious of, delirium rates and
Mhm. And the,
yeah.
the financial benefits of it as well. Like delirium alone increases healthcare costs in the most expensive patients by 40%.
Mm,
This weakness that they develop increases costs by 30%.
mm,
So they quickly see a decrease in time on the ventilator, how long they stay in the ICU, how long they stay in the hospital. If they were to track, sometimes that's variable, but they would see a difference in where they go after the hospital, if they go to a care
mm,
facility or to home, whether or
yeah.
not they come back to the hospital. All of those things improve with this, but they quickly see a huge return on investment. So it's been a really cool way to be able to get more support for this staff, more staffing,
Yeah.
more equipment, more things that they need to say, you can invest thousands to save lives, quality
Right.
of life, prevent all this harm. Um, but you will actually also get millions of savings in
Yeah.
return annually.
Yeah. Have you on your podcast had people who have been in both a currently typical ICU and people that have been in one of the awake and walking ICUs?
Yes, I think the first nurse I interviewed about that was a travel nurse that came to our unit during COVID.
Yeah.
And she was mortified when she first walked in. I of all people should have been realizing what it would be like for those travel nurses, but we just
Mm,
didn't think about preparing them because the rest of the unit is so used to it. Many of them have only worked there.
mm,
So no one prepared her to say, hey, patients are awake. Here's how we do it. Here's why we do it. Nothing. It was just like, okay, you're an ICU nurse. You've worked in other COVID ICUs. Get in there.
mm.
And she comes running out and she's like, they're awake in there, like just panicked,
Yeah.
thinking that something's gone wrong. And they're like,
Yeah.
why? Of course they're awake. They're human.
Yeah.
And so it was really shocking. And we even had some travel nurses cry because I thought
Yeah.
this was barbaric and humane. But after a few shifts, they start to realize how well these patients do, how different it is. And so interviewing that travel nurse after a while, she actually did an episode called Less Sedation Equals Less Work, talking
Mm,
about how much easier it is to care for these patients when they're not confused, trying to
mm,
pull out their tubes, trying to punch you, trying to get out of bed, that they turn in themselves or moving themselves. They just do better. And so there's actually kind of an ethical turmoil for them. I've had a travel nurse come in who initially, again, was shocked, different travel nurse, but he said, I almost wish I hadn't come here because
mm.
now my contract is up and I have to go to a different hospital and I don't know how to do that. Now
Wow.
that I know what I know and I know the harm that I've done and what could be, how do I go somewhere else?
Mm,
So those are the kind of testimonials that I've carried with me in my consulting journey to realize no one should have to feel that way, right? We should all be doing the right things for patients. There should be more options for well-intended nurses that want to practice this way to actually go and have a team that believes in this and does it. Um, I've
well, it's
interviewed
making
nurses.
sense of moral injury, right? Which is something that healthcare providers experience often. But that's like the thing that came up for me for somebody who's like, this is how I want to keep practicing, but I have to work. This contract is up. So just the impact of that on him as a human has got to be really intense.
Yeah, and there's moral injury just when patients are sedated and they're comatose and they can't be informed, they don't make decisions. It's up to the families. The
Yeah.
families grapple with, do we continue all of these interventions? The clinicians oftentimes know that the outcome's not going to be good, but the family wants to continue. And then we're like, nurses especially are left with providing care that they feel is prolonging suffering
Mm,
and prolonging
mhm.
death. That's a
Yeah.
huge cause of moral injury and burnout in the ICU setting.
Yeah.
So what they immediately really appreciate is patients be able to say, here's what I want, here's what I don't want. And they don't have
Right.
to struggle with that. And it's easier on families. But with moral injury as well, I've done my podcast since 2020. And so you have thousands of listeners throughout the world that are hearing this, realizing this, hearing it from survivors, understanding the research, and then they go to bring it to the bedside and to their teams, and they hit all these walls. And
Yeah.
sometimes they are persecuted. I mean, they've lost their jobs, they've been kicked out of the ICU, just crazy things have happened to some of these people for fighting for the right things. And so there's a lot of moral injury of being in that environment. People have said, I can't listen to podcasts on my way to work anymore because I hear it. Then I
Mm,
walk into the unit and I see exactly what you're talking about. And it's really hard. So I have
yeah.
lots of love and admiration for what I call revolutionists, people that are boots on the ground in the trenches, fighting against the system, trying to bring these changes. They
Yeah.
face a lot, and they keep going because they care so much. Like I mean, healthcare workers in general are there for the right reasons, and they are the best of the best. Um, but once they know what is actually happening, they don't stop until it's fixed.
Right. Ugh. I love the word revolutionist.
Hmm.
That's really powerful. And I do think that there are so many people, you and I included, that are trying to change the system. We're doing it in different ways, obviously.
Yeah.
Um, and so I think that is really powerful, but also like understanding that there are people that are losing their jobs because they are fighting. Because, on this podcast, there are clinicians that listen to it, and there are also a lot of people who are patients who've experienced medical trauma. And so I just think it's so, I hope hopeful for them to hear that there are so many people that are really fighting so hard to change the system. And, there are so many components to the system, this huge system, that are harmful, right? Both to the medical providers and to the patients in them. So I love that word, revolutionist.
And
I mean, it's,
survivors are such an important part of this revolution. I know it can
yes.
be very disempowering. These survivors leave the ICU, they go to another part of the hospital, and they're still just trying to stay alive and recover. And then we're like, okay, well, you're breathing, you've got a heartbeat, you're good to go. And then they try to go fit back into their lives, and they're not the same people anymore. And
Right.
there are things sometimes, especially if they were super high functioning beforehand, what's an IQ drop of 20 points, right? Huge to the person that's living with it.
Right. Exactly.
Outside
Yeah.
world, they're like, well, like you can still turn on the TV and you can still use your computer, which actually many survivors can't for many months. They can't even turn their computer on. Like that's how dysfunctional people come home as.
Mm,
But a lot of times these are not super detectable from the outside.
mm-hmm.
Then I've heard from survivors, they go to their primary care doctor and they're like, they describe symptoms of what we know now as PTSD, or they have agoraphobia, like they can't leave their
Yeah.
houses, or they have terrible social anxiety. They're having horrific insomnia because every time they close their eyes, they're reliving what they
Mm,
lived through during their delirium. They're having
yeah.
panic attacks. Their brain doesn't work. Um, but the primary care doctors are totally uninformed and are like, "You're fine. You're
Mm,
fine. It's fine." They they're gaslit. They're totally left alone to deal with this. No one gave them any kind of heads up. The families oftentimes are like, "You just survived. You're fine."
right.
The families are traumatized. They're trying to deal with their own trauma. They're just glad that they got made it home and that they're alive. They just want to move forward. And so
Yeah.
these survivors are left completely alone. I remember one survivor that I interviewed who's still such a close friend of mine. He was in his 30s. He had been in a coma for over 3 weeks, had
Mm,
terrible experience. He was a lawyer beforehand.
mm-hmm.
And when he tried to go back to work, when he stepped into the courtroom, he calls it time travel. But his whole environment would shift back to where he was in his delirium. He
Mm,
was lost.
yeah.
Um, and he did all this therapy and stuff, but he didn't really talk about what's going on as far as all of that time traveling and the delirium itself, more of to do with like depression and anxiety, very generalized things, because he was afraid if he had told him what he was actually going through, he would be institutionalized
Mm,
because
mm-hmm.
it sounded so insane.
Yeah.
And so he just wasn't getting better, and he actually was about to take his own life. He had
Mm,
letters written to his loved ones, and I think he was looking online for something and came across my podcast, and that's the first time he had found the word delirium.
wow.
And he was
Wow.
like, "There's a name for what I'm going through.
Yeah.
I'm not
Yes.
the only one. I'm not crazy."
Yeah.
And just like flooded me with emails, and he came on my podcast, and now like he's just made so much progress that he's speaking at conferences.
Oh,
He still can't practice as a lawyer, but he is getting his master's in public health. So,
that's amazing.
he's doing support groups. Like there's so much that needs to happen, but the community is largely unaware. But it's really interesting when I teach teams because there are decades of research on this. There are some amazing statistics, kind of like the ones I've shared.
Mm-hmm.
Delirium doubles the risk of dying, increases costs, right? All these things. But when I ask clinicians after all those webinars, what impressed you the most? What do you remember the most? Almost always they say the survivors' testimonials.
Mm-hmm.
So that is the power of the survivor. Like,
Yes.
yes, the statistics are convincing, but the survivor testimonials are compelling. But I've had
Yeah.
clinicians be like, well, the survivors that come back to visit us don't say anything about this. And I think that is such a biased group of survivors because who would want to go back and who was really able to go back to the very place where they thought that they were being held hostage and their worst life traumas happened, right?
Yeah.
It
And
can't be
also,
really, yeah.
well, just this area that we're talking about right now is like literally my area, right? Like this is why I run weekly peer support groups because like you said, to hear there's a word for something, and I use the word medical trauma. I know PICS is another word specific to the ICU, but to be able to show up with somebody else and hear that somebody else has had that same experience is just like, oh my God, I'm not alone. It's just this immediate, like, I don't know, softening in a way of like this body that's like, oh my God, there's something wrong with me. This is horrible. I can't do this. To, oh my gosh, there are other people and there's a word for it. And that's like a big part of what I'm trying to do is spread awareness about this phrase medical trauma, right?
Mhm.
For people to hear that there are traumas that happen in medical settings. Millions of people experience it, right? I think like a fraction of people actually know that there's a word called medical trauma and they're not alone in it. And like you said, like hearing from people who have actually been through it is so powerful. And the other thing I wanted to say too is sometimes going to a clinician can be really triggering for people. And so finding peer support groups, it's a different kind of experience. Like you were saying, for this friend of yours who like heard on your podcast, like, oh my gosh, like I'm not the only one who's going through this. I literally can't find a word that's strong enough to describe the impact that that has on somebody to know that they are they're not alone anymore.
Yes, and that like part of that healing seems to be dedicating their sufferings for something,
Yeah.
right? I went
Mhm.
back to grad school after a few years of doing travel nursing. So I'd sedated
Mhm.
patients, I'd done all the things. I even laughed about it, joked about it because I didn't know the harm of it, and I was just fitting into these other environments. But I actually really missed my first ICU, and I couldn't put my finger fully on it.
Yeah.
And it's the team, the environment, the patients. I didn't realize it was primarily the process of care that we were providing. But I ran back to that first ICU when I got a chance to go to grad school in Salt Lake City again.
Mhm.
And I had a lot of questions. I was like, hold on, these are even sicker patients than the ones I treated in these other ICUs.
Mm.
Why are they doing so well?
Yeah.
Why aren't they trying to pull the tube out all the time? Why aren't they thrashing like all these other patients I had treated everywhere else? And so that was getting me to ask questions, to look a little bit into the research, to ask my mentors there, the ones that had started that process of care. They were the ones that founded that process, but I didn't know that beforehand. So now I'm asking them questions. But what really sealed the deal for me was I was on a plane ride and I sat next to this man and he asked what I did for a living. I told him I was an ICU nurse going to grad school, and the color just dropped from his face. And he started
Mm.
to tell me what it was like for him to be in a medically induced coma.
Mm.
And he was
Mm.
in his late 40s. I never would have guessed that he had been critically ill, that he struggled with the aftermath of all of that. But
Yeah.
when I listened to him just sobbing to me, I was a total stranger, and he's just trying to talk about these experiences. I could tell there was a lot he couldn't still talk about, and it was over
Yeah.
4 years after his discharge from the hospital. He said he would never go back to an ICU, never do any of that again. But I was just shocked, and I thought this has to be an exception. This has to be a fluke, because no way this is a common thing. Because now I've worked in 10 ICUs, and we would have talked about this. Like, this shouldn't be the first time I'm hearing this 6 years into my career.
Uh-huh.
So I went to Facebook groups to ask survivors if they've had anything like this. And I thought I'd have to post onto the group a specific question. But as soon as I was admitted into the group, all I had to do was scroll.
Yeah.
And that's all about the cognitive impairments, the flashbacks, the PTSD, all these things. They didn't really have words for it, right? But the things that they were describing, I was like, this is just like what that guy was describing.
Yeah.
Without their testimonials, them talking about it, them allowing me into that space to learn from that, none of this would have happened. I wouldn't have
Yeah.
started my podcast. I wouldn't have started consulting. I wouldn't have understood. But it's
Mhm.
them being willing to talk about it, to share with each other, but also allow me some insight that has helped so much. And now it's they unknowingly have helped start and lead a revolution.
Yes. Oh, that's beautiful. That's so beautiful to listen to the people who've experienced it and for that, their stories and what they've been through to create change is really beautiful. And it's interesting because I experience that with a lot of the people that are a part of my community is I'm like, y'all, you're making change, like you're stepping in and changing things. And I think that it's a huge for all of us who've experienced medical trauma, there's so much healing and growth that comes when we're then able to turn back and we're able to help other people have a better experience than we did. I think that's amazing. It's
And
beautiful.
if those that are listening are survivors, whether you've been in a medically induced coma, you've been in the ICU general, or even on the acute care floor, delirium happens in all of these settings. I mean, it happens in the nursing homes, in rehab centers. It happens everywhere. But really high rates and severity in the ICU. But if you have endured that, I invite you to go back and teach your team about it. And I know that might be really hard, but if you feel like you're in a position to be able to do that or even willing to try, you can make such a difference. It is so helpful when they hear it from their own survivors.
Yeah.
And if you're able to say in a way, I shared this with you so that you change these things. This needs to change. Like survivors that stick it to the clinicians to say, thank you so much for what you did. I understand you didn't intend to cause harm, but here's what happened. Please change this for future patients. That is so powerful. But I think survivors feel like they can't say anything because they're supposed to just shut up and be grateful.
That they're alive.
But you can be grateful and be a part of the revolution at the same time.
Yes, absolutely.
And I don't think they don't have to be isolated. They can actually both can be very powerful.
Yeah. I mean, life is full of nuance, right? Nothing is ever black and white. And so, yeah, to be able to hold both is so important. Well, that also kind of leads me into that third, question that came up for me when you were talking earlier is, what advice do you have for somebody who wants to ensure that if they do end up in the ICU, that they have a better outcome? And there may actually be family members listening who have loved ones in the ICU. So what are things that we can do to minimize the risks of delirium, to maximize the chance that we're surviving the ICU and walking out of the ICU? What are things people can actually do at this moment?
I think a great example is in the first survivor I ever interviewed on my podcast, Walking Home from the ICU. She's on episode 3. And she had ARDS, again, that condition I mentioned where the lungs get very inflamed and stiff. And she was put on that conveyor belt of sedation and mobility. And she talks about how she tried to save burning babies for weeks. It had a terrible rehabilitative process. And as soon as she was able, she went to an attorney and then she had documents drafted protecting her from sedation. So I call her a DNS. We have DNR, do not resuscitate, DNI, do not intubate, or DNS, do not sedate unless it's absolutely essential to save my life. And so she actually had ARDS 2 more times.
Wow.
Amazingly enough, like that's just really bad luck. But the next 2 times, her worst complaint was that she was bored. But she was so grateful that she had those documents drafted, that her family was very clear. And she had just interesting insights. Like the clinicians were not used to that, but they had to honor it. And at one point, there was a doctor wanting to run a test on her, and the family was saying, no, that's too high risk. We don't want to do that. And she kind of waved and raised her hand. She's like, hi, I'm right here. Me, I make the decisions. Even though she couldn't talk, but she could write. She had a breathing tube in, but she was awake. She was informed. So she gestured and she grabbed the paperwork and signed it and authorized the test for herself. And the doctor was just floored, which is really sad from my perspective. Because I'm like, it shouldn't be so crazy that a patient be making their own choices for their own body during super important moments. But anyways, she just talked about how she's not afraid of the ventilator. She's not afraid of sedation, of ARDS. She's terrified of sedation, but she had documents drafted. So we have advanced directives, which are usually very, very generic. Like, do CPR, don't do CPR. You give me antibiotics, but you can't put me on a ventilator, right? Each state has its own advanced directives, but I would invite you to fill out your own advanced directive. And usually they have free text area. And there you can write, I don't want to be sedated unless it's essential to save my life. I want to be awake and involved in communicating and mobile. And this is so much easier when this is done shortly after the procedure of placing the breathing tube, right? We can sedate them for that procedure. That's short periods of time. That's great. But to be able to wake up right away and have your cognition and your muscles and your fine motor skills intact enough to hold your cell phone, that sets you up to be able to kind of call the shots in your care the rest of the time. So communicating that with your loved ones to say, hey, I really don't want to be in a medically induced coma unless it's absolutely essential. If I end up in the ICU, make sure you're questioning whether or not, make sure that they prove that you actually have to have sedation, turn it off right away unless, again, there's a reason for it. I have a podcast for families called Walking You Through the ICU. that serves as a resource to those that are actively in the ICU with their loved ones, to walk them through the process of advocating, understanding. Again, everything I've talked about is as far as why we do it. We're not trying to harm patients, but here's the perception of the clinicians that you are up against. And even interviewing a family that was able to advocate for their loved one and totally course correct the trajectory of that patient's life. And I'm always happy to be a resource. There's just a lot to prepare for, but those would be the first steps of making sure your advance directive is in place, that you communicate with your power of attorneys, your loved ones, your care team. And yeah, if you are headed that way, to having that conversation early to say, okay, I understand I might need a ventilator at some point, especially certain chronic conditions. You know, some of your medical trauma survivors may have, you know, frequent readmissions and chronic things that may put them at risk of being on a ventilator. It's never too early to just have that conversation.
Yeah. Yeah. This is so much interesting information and helpful information. One thing that I love to do at the end of each podcast episode is to ask my guests, like, you've already shared so many golden, nuggets of information, obviously, but is there one thing that you really want anybody listening to walk away with?
You're not alone. Surviving is part of it, but you're not alone in wanting to thrive.
Yeah.
You're allowed to talk about how your journey, whatever that looked like, impacted you. And again, it's not being ungrateful. It's just being honest. Seek out those that have shared experiences and educate your clinicians. Whether, again, whatever kind of medical trauma you have, we need your voices to help us improve how we're caring for patients. You sharing what you've been through, what you still go through, helps guide care for generations to come.
Yeah, that's powerful. Thank you. And I also would love for you to share how people can learn more about your work. I'm going to share a link to your podcast, of course, but how else can people contact you or learn about your work?
www.daytonicuconsulting is my website. You can also find me on Instagram at Dayton ICU Consulting. There are a lot of pictures and videos of patients awake and walking if you want to see what that looks like, because that can sound crazy. It's really helpful to join in those comments as well. So if you struggle with post-ICU syndrome, to weigh in on those conversations. Because you'll hear clinicians being like, this is crazy, this is unsafe, this is inhumane. Why aren't they sedated? If you've experienced that, it's really helpful for survivors to say, hey, it's not what you think it is. It's really hard to dispute someone with personal experience. Like, you guys are the experts. So, find me on social media, on my website, email me. You can email me from that website. Please chime in, join the revolution.
Yes, beautiful. Thank you so much for sharing your time and your vast knowledge and bringing this topic that most people are unaware of.
We're changing that.
Yeah, right. Well, thank you so much. Thank you so much for being here and for caring about bringing more humanity into healthcare. And if this conversation meant something to you, please share it so more people know they're not alone in their medical experiences. You can find resources, education, and our peer support community at medicaltraumasupport.com. And if you enjoyed this episode, please follow, subscribe, and leave a review. It really helps more people find this podcast. Take care of yourself, and I'll see you next time.